All right, so Dr. Greene has practiced complementary, integrative, and orthomolecular medicine since 1983. She is an expert in bioidentical hormones and the treatment of tick-borne diseases. Tick-borne diseases, sorry. Dr. Greene treated her first case of Lyme disease in 1989. Since then, she has closely followed Lyme and chronic infectious disease via patient care, diagnosis, treatment, and ongoing research of Lyme disease and other TBD, tick-borne diseases. Dr. Greene has not only followed the research and scientific knowledge regarding these newly recognized bacterial diseases, but since 2004 has been an active member and a board member of ILADS, the International Lyme and Associated Disease Society. Since joining ILADS, she has brought a new sense of awareness to the medical community, where she contributes her time and expertise to patient research and patient advocacy. She currently serves as the Director of Education for ILADS. She will be speaking to us tonight on the connection between chlamydia and heart disease. Please give a warm welcome to Dr. Greene.
So thank you, Dr. Miller. I think the reason he thought of me is we share some patients. We have patients in common. And we had a patient with a lot of prostate inflammation. And I observed that sometimes there are mixed infections that cause these kind of inflammations. And I am very interested, basically because I do second opinion work. I'm kind of a medical sleuth to try to figure out why people stay sick, even though we think we did everything right. I'm very interested in multiple infectious disease. The bugs are very smart. They keep evolving just like we do. So I was going to talk about atherosclerosis, since it's a heart talk, and since I happen to have slides on this. And cause, I don't think you can see this, I think it's too light, but cause is a very rare word in medical research these days. It's expensive to ask why, and you usually don't end up with a product to sell, which is what you have to do now in medical research. Root cause, why something's really happening, is almost a question of the past. So why do we care about finding a cause? Because if you find a cause and you remove the cause, then the problem's gone. If you can really find a root cause, then you get to the bottom of what's going on. For instance, and this is from a paper by Ewald that I didn't quote, but I'll give you the reference to. If Mycobacterium tuberculosis is not present, you do not have tuberculosis. So this was mentioned, and it's right. What we're doing in research mostly is looking at risk factors and correlating risk factors to whatever the, quote, disease or problem is. And what this ends up making us do, this is a philosophical talk, by the way, is we shoot the messenger. So statin drugs were mentioned. So they notice that high cholesterol is associated with high cardiovascular event, at least sometimes. So they decide cholesterol's the problem. They don't say, well, why do people have high cholesterol? What good does cholesterol do? Same with TNF alpha blockers, which are these are my 3 pet peeves right now. TNF alpha blockers are anti-inflammatories. It turns out if you have bad arthritis or bad lupus, or for that matter, bad Lyme disease, you have very high levels of a cytokine called TNF alpha. And it's very inflammatory, it hurts, and these people hurt a lot. So what they decided to do was knock out the TNF alpha, just get rid of it, it must be bad, it's making people hurt. But that stands for tumor necrosis factor alpha. You kind of want a tumor necrosis factor around. You want something that's going to remove your tumors when they come up. And indeed, many of the people who take TNF alpha blockers end up with overwhelmingly bad infections. And same rituximab at $10,000 a shot basically wipes out all your antibody-making cells in the body. And it's being used everywhere, not rituximab per se, but this kind of B cell killer. It's even being used in osteoporosis. I mean, I couldn't believe it when I saw that. So again, we're shooting the messenger. Now, I'm not saying that these drugs don't have a place. They do. Sometimes people are hurting so much, and you've done everything you know how to do, that the risk, right, is less than the possible benefit of giving them that TNF-alpha and controlling risk. So I'm not saying they never belong, but we're using them casually and maybe foolishly. So evolutionary biology, which is really the root of this talk, and it's the root of biology, it's been the basis of biology and therefore the basis of medicine since Darwin, maybe a little before. But we aren't always smart. We understand that. So what we should be thinking about is if there's something in the environment that we'd rather not have there, whether it's a microbe or, or a toxin from a microbe, how do we modify, how do we get the environment to put pressure to get rid of that bug? So I'm going to talk about this model of disease, which is by Ewald. So this is really the exciting part for me of where medicine's going, because very often we think, well, a disease is caused by genes, you know? And if you're unlucky enough to have Tay-Sachs when you're born, or mucocutaneous candidiasis in full expression, you can pretty well say that's a full genetic disease. It's going to kill you by the time you're 3. Or epigenetically, if you happen to be too close to Fukushima when it melted down, then your genes are going to be greatly harmed, and that's going to take you out right there. And epigenetics are basically forces that happen to change your DNA while you're alive. If you remember high school biology, Darwin always won over Lamarck. Lamarck kind of said, Lamarck said, that traits that happen during life are handed down. And I remember my biology book because it showed a mouse with a tail cut off. And it said Lamarck believed that the mouse's offspring would have no tails, right? He was a lot smarter than that. Lamarck was trying to talk about epigenetics. So things can change our DNA while we're alive that at times are handed down to offspring. And finally, there's an infectious component. So sometimes, if you're unlucky enough to be selenium deficient and get Ebola, you're going to die very quickly. And what you said, Steve, that's pretty interesting, because why would a virus want the host to be really sick? Because part of the argument with these bugs is that they infect you, but they generally don't kill you. You're their world. They want to hang around. They want to live with you for a long time. So anyhow, discussion later. So let's talk about a specific genetic marker that correlates with atherosclerosis. It's the epsilon 4 allele of the apoprotein E locus. And if you're unlucky enough to be born with this, you have about a 40% higher risk than people without it. For atherosclerosis, you have a higher risk for stroke, Alzheimer's, certain kind of Alzheimer's, and very, not all multiple sclerosis, but very severe, rapid, progressive multiple sclerosis. This is a bad gene. It reduces fitness by greater than 1%. And I'm no mathematician, but evolutionarily, this gene should not still be around. We should have selected it out. It should be so bad that those people kind of can't make it to offspring. So why is it here? So that's the genetic possibility. What about epigenetic? The epigenetic contribution to atherosclerosis we're going to talk about is smoking. Smoking, as we all know, correlates with getting atherosclerosis and heart disease. I was taught that. And even secondhand smoke, even very low little exposure to smoke, can correlate with a much higher risk. The reason given is usually the oxidative effect of smoke products on lipids, damaging the inside of the vessel, and leading eventually to atherosclerosis. But again, mathematically, models show that sometimes the smoke is so low, it's hard to argue that. But if you have the epsilon 4 allele of the ApoE locus, and you smoke, your risk of atherosclerosis suddenly jumps to somewhere around 60% above norm. So what about infectious? How does that possibly affect anything? I don't know if people here remember, but maybe 15 years ago, 10 to 15, headlines appeared, one in the New York Times that says, you know, is heart attack infectious? And it was indeed about Chlamydia pneumoniae. This is not the bad chlamydia. I have a hard time getting patients to let me test this. But it is a common bug. Probably 40 to 50% of people worldwide will carry this bug, and it is concentrated in different populations. This is not the best paper in the world. I just thought it made the point. So atherosclerosis induced by Chlamydia pneumoniae. So like everything, when you're looking for a cause, same thing, how does smoke damage vessels? Well, how could Chlamydia pneumoniae possibly damage vessels? I'm sorry, I'm ahead of myself. One way to tell if a disease is genetic or infectious is to look at twin studies. Maybe you know this. It's called a concordance rate. If it's genetic, the concordance is going to be very high. If it's infectious, it's around 50%. It's interesting that atherosclerosis in twin studies is about 50%. The same as TB. And so this was one of the arguments used to say, we think maybe atherosclerosis is infectious. And this is the way that chlamydia can harm vessels. It's lipophilic, it oxidates lipids, it loves lipids, just like smoke might oxidize lipid. High iron is often associated with a risk of atherosclerosis. We don't give iron to people. We worry that it's going to increase inflammation. But it also makes chlamydia grow faster. It's one of the medical school trick questions. Should you give iron to someone who has low iron with infection? And then it activates those very immune cytokines I was talking about, the TNF-alpha, the IL-6. These things that are very inflammatory will go up, and so the theory would be it's not that the vessels are damaged by the development of the plaque from smoke or from the bad luck of you having an epsilon 4 gene. It's actually that this little bug that loves these little membranes of your endothelium of your cell wall in the blood vessel is sitting there eating them, causing the initial damage, and then you're getting everything else in. So what I think, and it's not just me, what medicine's going to is their genetic predispositions that increase your risk. But in this case, with this epsilon 4 allele, it may be that it only increases your risk if you get infected by Chlamydia pneumoniae. And it's true, I treat a lot of Lyme and complex tick-borne disease. And we now think that maybe a gene called the MTHFR gene, which is 10% of European populations have a mutation in that gene that makes them a little hyperclotable. We think maybe that's the people who are having chronic Lyme and can't get rid of the bug. Maybe that's what's going on. But this is what medicine's looking at, and I think it's very exciting because it means that maybe we can identify young, that person, let's not let them have mycoplasma pneumonia when they're 18, but that person over there is fine. It's normal flora for them. Maybe we can figure that out. So I didn't erase that. So there's evidence out there, and this is part of the problem when you try to prove a cause. There's evidence out there that chlamydia or treatment with antibiotics cures atherosclerosis. And there's peer-reviewed, wonderful papers that show treatment with antibiotics doesn't cure atherosclerosis. And the same with the genetic or epigenetic. So what we want to do is put this together. We want to understand interactions in the environment, and then we can protect people better. So that's the summary. And this is what people normally think about chlamydia pneumoniae and what things it might cause. And one of the things it may cause is certain kinds of arthritises that are based in the large joints. They're called spondyloarthropathies. They're things like ankylosing spondylitis, if anyone has had that. And there's evidence, again, in the literature that if you have those kind of arthritis, they're called post-infectious arthritis. You get some chlamydia and you end up with this awful arthritis, and it's very painful and it can harm your joints and your back, et cetera. Well, a guy named Carter said, there's all this evidence that maybe it's not post-infectious, maybe it's current infectious. So he proved in some cases that the bug was still there. He did PCR in the joint fluid, and then he treated people with 2 drugs. This is one point I wanted to make tonight, because these drugs that are persistent and playing with each other, they can talk to each other in biofilms, they can kind of share the host, which happens to be us in a lot of cases. They cannot be eradicated with one antibiotic because they have different forms and because they stay in different places in the body. So what Carter did was put people on 2 antibiotics for 6 months, have to do it for a long time, and there was a significant improvement in the people on the antibiotic versus the people on controls. So, punchline, microbes live in a community just like we do. They live together, they talk together, they live in something called biofilms, and it's all microbes. The fungus are part of the co-infection. Bacteria are in there, parasites are in there. And what we really want is it to be one big happy family. We want those bugs, and we want them to be the healthy bugs. So it goes back to that, thinking about how to make the environment, the right environment to select the bugs we want. And that's part of the story too. So I have this book just because it talks a little bit about, from the view of tick-borne bugs, what Dr. Miller was talking about in terms of co-infections in different organs. And he kind of puts this together in spite of the terrible name. I think his editors made him name it that. So the question is, chlamydia pneumoniae, can we eliminate the chlamydia pneumoniae in patients and eliminate atherosclerosis? Can we do that? Is it a root cause in some patients? And to answer that question, we've got to start being smarter about what questions we ask when we do research. Thank you.
So, questions?
I have a question that I learned from this man here, Steve Fowkes. An even more root cause is, why are the people getting these infections? What is it about their immune system, their general health, that allows the infection to?
So it's a co-evolution, right? So in some cases, the bugs, for instance, chlamydia has figured out a way to evolve that if you have the APO4 allele, they can get in. So some of it is co-evolution, finding a niche that works for that bug, right? And some of it is that, the bugs can also suppress the immune function. Just like the bugs can eat up the selenium, you know, if you're unlucky enough to get a bad Ehrlichia infection or a bad mono infection for that matter, there's lots of evidence you get opportunistic bugs because they go after the white cells. And so there's lots of different reasons, but I think we really have to look at coevolution and things that evolve and are our friends. I also think, and I don't know, Steve, maybe you do too, there's a lot of, we've poisoned ourselves. and I mean, part of it is that, you know, but you can't think, oh, it's all that, because the bugs are changing. You know, they want to live too. And we'd like to live happily with them, right? If we were sterile, we'd be dead. If there were no pathogens, no microbes in us, you know, we wouldn't survive. They're mostly our friends. But that would be my answer.
This whole idea that association establishes causality, I find in a lot of scientific papers, you'll see the cause word thrown around all the time. And I remember one time, you know, looking at a group of researchers who were making the claim that herpes caused Alzheimer's disease, because when they would do autopsies on people's brains with Alzheimer's disease, something like 50% plus or minus 25% would have active herpes infections going on. And I always like to reverse it anytime I see that, because there's an association. They say the causal error goes one way, and I'd say, well, it's just as likely that it goes the other way.
Exactly.
And that there's a mutual cause that is doing both. And so my suggestion is that the chlamydia infection can be caused by cardiovascular disease, that the
Exactly.
cardiovascular disease process would take down the host resistance so that they become susceptible to the infection, and then the infection, when that opportunity comes along, the infection goes, oh yeah, it's party time, and implants itself in the tissue, and that the underlying health or disease state of the vascular lining, for example, is a common cause of potentially of both of those kinds of factors.
No, I agree. I think in order to answer that question, we have to start asking the right question and looking around. And I think in some cases, it's going to be chlamydia, if you've got the right genetic makeup. We also have to look before the atherosclerosis is rampant. We've got to look in young people to see, you know, what the start is. And we have to do these linear studies that are expensive and nobody really wants to do. But that is what I'm saying. You can't say it's this way, you can't say it's that way, because there's evidence for both.
playing
And
both
it's probably
ways.
very complicated. I mean, it's, you know, but the question here, the question I tried to pose is, okay, can we figure that out? If you take a South African, and you, see if I can remember this, if you take a South African who has, who's in South Africa with a epsilon 4 allele, he doesn't have much of a higher risk of atherosclerosis. If he moves to England, he will in a generation have a much higher risk. Now maybe that's food, okay, maybe that's food, maybe that's the air.
Vitamin D from the
there's
climate.
also a higher concentration of infection of chlamydia there. So I think if we start doing those population studies and asking those questions and not sitting with correlation as our only answer, that's the way, you know. But in general, the feeling has been what you said. Oh, you know, the damage is slow over years from bad habits or bad luck or poisons or whatever. And then the bugs get in because you knock down the immunity. But boy, if you look at some of these bugs, they get in and they arrange immunity in their direction.
Yeah.
It's really
And
quite
it's like,
interesting.
I would describe it as a kind of cascade failure, that you leave various doors open because you might be exposed to mercury and you might be exposed to estrogenic chemicals in your water supply from drinking bottled water, and you might have a zinc deficiency or a copper deficiency, and those. So we're losing our connection to nutrition and wild diets, and we're eating more processed foods. All these kinds of things. We're exposed to EMF like we've never been before. We're vaccinated like we've never been before. All of these kinds of factors are changing around us dynamically, and they're all playing a role.
Agreed.
So when you get to a point when you do too many things that are adverse and counterproductive, they all kind of cascade and things get out of control. You start to fall apart fast because each thing opens the door for something else, which lowers your resistance, that causes something else to happen, that lowers even further, and they all feed on each other.
Agreed. One of my things I did when I did primary care is I would, I would say to patients, well, you're going to have some cheat. Everyone has to have some cheat. So let's look at your family history and see what things are safe for you to cheat. So I would say that's right. But there, I mean, you know, one of my first cases as a med student, I walked into the room and there was this 90-year-old guy who finally had gotten lung cancer, but he had smoked since you know, he literally said, "Knee high to Gordonstock." So, you know, what about that? And how do we figure out, you know, what's riskiest for whom? Because I think we can start to do that, and I think it's interesting. Do I think we should clean up our environment? Yeah.
Hi, I'm going to second what Steve has said. What I'm finding difficult in a lot of the medical literature is that they are looking for still at one cause all the time. You know, did this cause that? And I see things as being much more multifactorial, and consequently, when we keep on looking at the one factor in the research, we keep on looking at for one factor that's the causation, we end up continuing to believe in the magic pill formula for getting better. And I think that that's where we have totally gone wrong in Western medicine in terms of how to get people better from illness and keep them well and or deal with prevention. We want to deal with one thing, or if you're talking about prevention, tell me the one thing, but it's no longer one thing. And our populace with EMF and everything else, we're not thinking as well as we used to, and that's pretty clear. And grasping all of the threads of a multifactorial disease seems massively overwhelming to the average person, and I think to the researchers, because I don't think I doubt that we have the computer capacity to factor in all the different factors and how they swing left and right, let's say, or up and down, and come up with a model, because our models have become, have been over time so simplistic. And making them less simplistic will involve multiple fields of study working together, and that doesn't tend to happen in research either.
No, I agree with you. I think you can be happy that medical research has quit looking for causes. But I also think you still have to look at the multiple factors. You have to go back to a healthy person and come forward and ask those questions. And I worry that one of the things we've lost is kind of infectious processes and thinking about them. But I agree, of course it's multifactorial. I think insurance, more than anything else as a doc, is forcing the docs into doing one thing at a time.
And I'm also seeing, and it's very regretful, and I'm also seeing, and it's very regretful when you're saying going back to when the person was well. When I do a history, I go back to birth or the fetal stage. And the children nowadays, they don't have a sense of wellness. They have no idea what it is. Or very rarely do I find a child who's robust and full of vigor and what I call piss and vinegar, very curious and just ready to go. That's the way I remember the children on my street being when I was a kid. And you just don't see it nowadays. So dealing with the current young population, it's like, when were they healthy? You know, so that's going to be a big challenge, I think. I don't think there's a baseline of health. Back to Steve.
Did you have a question, Kiki? Well,
What is the test for this type of pneumonia?
There are, okay, so it's named a pneumonia, but it goes elsewhere in the body. There are several tests. So for instance, if you're looking in the joint space, you do a PCR, you look for the DNA of the bug. You can do antibody tests for it. And the most, you want an IgA antibody test. If that's positive, then the bug's active. So many of us have this bug that an IgG is not very meaningful unless it really changes, goes up and down a lot. And an IgM, which normally would be the thing you'd look at, because this is mostly a mucous membrane bug, is probably not as important unless, again, it's very high. So PCRs and serology.
I've been reading Dr. Horowitz's book, and it wasn't clear.
Have you heard him talk?
What?
Have you heard him talk? His book is like that, I think.
Okay, so part of it didn't get on the tape. I'd like to point out one example of how this kind of cascade failure can happen, specifically as it relates to cardiovascular disease. So there, like the RATH protocol talks about the role of vitamin C in collagen maturation, and the role of the lysine and proline in the structure of collagen. And when collagen maturation doesn't happen very well, then there's localized inflammation because the body has this collagen replacement mechanism that's always going in place. And so there's this class of enzymes, metalloproteinases, that come in and say basically, okay, this is bad collagen. They tear it out and put new collagen back in. But if your collagen maturation mechanism isn't operating, the collagen that goes in is just as bad as the collagen you took out. And so you end up with this chronic inflammation pathway, which is a nice environment for a microbe party. So it turns out that the immune system, for example, has all kinds of compromises that it does dynamically to ensure our survival. Like, for example, when you get infected, you run a fever, and your liver starts to sequester iron, copper, and zinc, and it starts to burn up your tryptophan, because certain infections grow on tryptophan, certain infections grow on iron, as you mentioned, and copper and zinc. Well, copper not only is a growth factor for microbes, it's a maturation factor for collagen. So if you take your copper down for a week, your collagen isn't going to fall apart. But if you take your copper down for 6 months, your collagen's going to fall apart. So this idea of having a mechanism that's supposed to resolve an infection in 2 days that doesn't resolve after 6 months, that kind of thing totally changes the game regarding an adaptive mechanism that becomes a pathological mechanism.
So I have a question for you. You probably know this. Borrelia doesn't use iron. It uses manganese. So what would those repercussions be?
As far as I know, the body doesn't sequester manganese, but I really don't know. I know about copper, iron, and zinc, that those are active sequestration mechanisms that have been characterized for decades, many,
I know
many
that
decades.
you if your SOD is low and you replace manganese in people with some aching, about 45, their aching often goes away. There was a famous basketball player who was in Portland, where I grew up, who had manganese deficiency, and they figured it out. Yeah.
Yeah,
So that's all. I wondered
yeah.
if you learn any more, tell me.
My question is motivated by a personal interest in C-reactive protein, okay, as a marker of inflammation, which can be due to oxidation of lipids in the result in the arteries, okay. I just came up with a result of a C-reactive protein test, and it was 3.8. That's high. I don't believe that it's due to heart artery inflammation, because my pulse pressure was only 50, and I had a great verdict from Stanford cardiology looking at the pulse length, when the aorta opens up, okay? So what's your experience with patients who have high C-reactive protein results?
So again, I mostly see people now who have chronic infections, and they often have very high CRPs. I don't think Borrelia causes high CRPs, but I think some of the co's do, Bartonella, et cetera. You may know that chlamydia, when it started, could it be the cause of atherosclerosis? If you had chlamydia with a high CRP, they would treat the chlamydia to bring the CRP down. What I can tell you is in my Lyme patients, and that's a capital L, so that they aren't always, it's not always the bug of Lyme, but tick-borne disease patients, if they have a really high CRP and a high pathogen load, as I treat the pathogen load down, the CRP comes down. And it's often associated with pain. I don't know if you've got that association. I mean, I've seen 15, 45, 30. You know, sometimes they're very high CRPs.
That wasn't the high sensitivity test.
Oh no, I do the high sensitivity.
Would that make a difference?
It picks up, it gives you the lower numbers. It gives you, yeah, the lower numbers.
I think it might be high homocysteine. Is that possible?
You think the CRP? That's interesting. I don't know. I don't think so, because I see a lot of high homocysteines and give the triple Bs and watch them come down. I will look. I will start asking myself that question.
What do you see with regard to Mycoplasma pneumoniae or fermentans in terms of cardiovascular disease?
Ooh.
Because I know of some cardiologists that that's the first thing they look at.
Oh, really? Well, I don't know a lot specific to it. I am working on a basics learning module, so I've read recently 2 mycoplasma, reviews, and I know mycoplasma is the smallest bacteria known. It actually, they thought it was a virus until they got the electron microscope because it went through the viral filters, and it gets near. Who did what? Oh, on the fermentants?
Yeah.
Well, I know Garth Nicholson's work, but anyhow, I think it's one of those bugs that if it gets the chance, it has been associated with meningitis, with encephalitis. About 50% of childhood asthmas are associated with mycoplasma, and it is a really common bug. I used to say it was normal flora. I still think it is a lot of the time. Maybe, again, if the system's healthy, maybe it's normal flora.
In my experience, and this is just my experience in my population, about 50% of the time CRP is gluten insensitivity. And you reduce all the gluten, CRP comes down. And the other 50% is a whole bunch of other causes. Sometimes it's exogenous, sometimes it's endogenous. So the main thing about the high CRP is just one more inflammatory marker. And that's what I look for, we'll discuss, is what are the whole series of inflammatory markers. The CRP, sedimentation rate, fibrinogen, arachidonic acid to EPA ratio. So there's a number of inflammatory markers that we can look at. And CRP is just one of them that tends to be one of the most common ones.
I'm curious, I've always thought of CRP as more likely to be infectious, SED rate more likely to be autoimmune. I was taught that somewhere along the line. I don't think I read that. But it seems to be true. When I get a super high SED rate, I'll often find the ANA is actually elevated and I have a dsDNA or something. So I'd love to.
Yeah, but the interesting thing is why you can have a really high CRP and the SED rate's normal, or a really high SED rate and the CRP is normal.
Yeah,
They
exactly.
measure different fractions, and that's the reason why, once again, I look at cascades. I don't look at just one measure. CRP is good. If it's elevated, I'm worried, but you look at, there are other measures. So just because your CRP is low doesn't mean you're out of the woods. But if it's high, you got to look for the causes. Sometimes it takes a long time. I had one patient, we couldn't figure it out for a year, and it turned out that her husband, they would buy houses and they would fix up houses. And every time they go into a new house, her CRP went up. And it turned out she was allergic to dust. And as soon as they got the house fixed up and everything was ready to sell, CRP went down. So it can be multifactorial. So I don't always see it that it's for in my population, it's not always infectious.
Yeah. Oh, it's not.
Okay, so we're going to take a 10-minute break here and then get ready for Dr. Miller's lecture. If you haven't checked in at the front here, please do so. Like I said, we're a nonprofit, member-driven organization, so everybody checking in. Thank you.